Good evening, everyone, and thank you for joining and welcome to today's ESC webinar on heart failure, understanding the evidence behind the current guidelines relating to the ESC 2021 clinical practice guidelines on heart failure. I'm Professor Teresa McDonough from King's College Hospital in King's College, London, and I have the pleasure tonight to be joined by one of our fellows, Dr. Antonio Kanata, also from King's. The aim of this webinar is to give you a better understanding of the main changes in the ESC heart failure guideline, the reasons behind them, and to illustrate how they can be thought through and implemented through clinical case presentations. Now, this session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat, and I'll look at a selection of them and try to answer them. For the best learning experience, we also invite you to participate in the online assessment, which Dr. Kanata is going to punctuate his clinical presentation with some MCQs. So do keep on your toes and try to answer those and keep us on our feet as well to think about your answers. So I'm going to start by just taking you through what I think at least are the newest and key messages in the 2021 heart failure guideline. These are my conflicts of interest. Now, obviously, the guideline's been published since August 2021, and I want just to say a few words about the background to the guideline so that we can put the evidence into some context. A guideline, of course, is a consensus document. It's not one individual's idea about how to treat heart failure, and in this case, it was the consensus of a large task force of 31 individuals, including 2 patients. We considered published evidence until the end of March 2021. So the guideline becomes a little bit out of date thereafter, and in particular, regarding the section on heart failure with preserved ejection fraction, there are developments since then that are not included in the guideline. But apart from that, it's pretty up to date. Like all ESC guidelines, it considers really only high quality evidence. And we strictly applied the ESC rules for assigning classes of recommendation and levels of evidence, and they require that more than 75% of the task force agree in anonymous voting about a therapy or intervention being in a table of recommendations and what its class of evidence, recommendation or evidence should be. Now, it's a very big guideline and we can't go through all of it late on a Friday night. So I thought I'd focus on what is new since the 2016 guideline, in particularly in relation to the chronic heart failure section and comorbidities. There are updated sections in the guideline on acute and advanced heart failure, expanded sections on cancer, cardiomyopathies, and very importantly, the addition of quality indicators. The whole purpose of a guideline is to improve patient care, and quality indicators help us improve our practice by giving us benchmarks to audit our practice and therefore give ourselves targets to try and improve care. So first of all, regarding the definition of heart failure, we really didn't change very much the actual definition of heart failure. It still has to be a symptomatic condition, which is of course due to an underlying structural or functional abnormality of the heart. We did change the classification of chronic heart failure according to left ventricular ejection fraction. Heart failure with reduced ejection fraction remains the same. Patients with symptoms and or signs with a left ventricular ejection fraction less than or equal to 40%, because that closely aligns to the major treatment trials for patients with left ventricular systolic dysfunction. We renamed the previous heart failure with mid-range ejection fraction into heart failure with mildly reduced ejection fraction. That relates to those patients whose left ventricular ejection fraction is between 41 and 49%. Why? Because if you look at epidemiological and registry studies, these patients more closely resemble patients with HFrEF than those with HFpEF. And in terms of their response to therapy, they respond in a similar manner to those with reduced ejection fraction heart failure, albeit to a slightly lesser extent. The definition of heart failure with preserved ejection fraction, we did not change. Symptoms are signs of heart failure with an ejection fraction greater than or equal to 50%. But remember, you also have to have other evidence of a cardiac structural or functional abnormality consistent with LV diastolic function, dysfunction, raised filling pressures, and raised natriuretic peptides. So in terms of diagnosis of chronic heart failure, taking a patient with suspected heart failure and taking them through the pathway to actually diagnose them with chronic heart failure, we have really highlighted the role of the B-type natriuretic peptides as rule-out tests. So if your NT-proBNP or your BNP is below the threshold, you really should be thinking about other causes of the patient's breathlessness, tiredness, fatigue, ankle edema. Remember, they're rule-out tests. If the circulating concentrations of the B-type natriuretic peptides are raised, you then have to go on and prove that elevation in those biomarkers is due to a cardiac structural or functional abnormality. That's normally by going on to do echocardiography. Once you confirm this diagnosis for the chronic heart failure patient, then you separate them into the phenotypes of HFrEF, with heart failure with mildly reduced ejection fraction, or HFpEF. But you remember, you can't just stop there. You have to go on and determine the underlying etiology and also look at the comorbidities before you can actually think about treating the patient effectively. So let's look at the main changes for those patients with heart failure with reduced ejection fraction at the main drug therapies. There are no changes to the class 1A indications for ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. They all remain. There is a new class 1A recommendation for the use of dapagliflozin or empagliflozin for all patients with HFrEF, whether or not they have type 2 diabetes, to reduce the risk of hospitalization for heart failure and death. That's because we looked at the results of the DAPA-HF trial with dapagliflozin and the EMPEROR-reduced trial with empagliflozin, both trials reducing the composite endpoints of cardiovascular death and hospitalizations for heart failure. So these drugs should be added in to the other 3 ACE inhibitor, beta blocker, or MRA. The positioning of sacubitril/valsartan remains class 1B based on the results of the PARADIGM-HF study for patients with chronic heart failure if they remain symptomatic on an ACE inhibitor or an ARB, switching over to sacubitril/valsartan. In terms of other changes in the guideline, you'll see there's a new indication for the soluble guanate cyclase stimulator vericiguat, looking at the results of the Victoria trial, where vericiguat was added on to optimal medical therapy for patients whose heart failure was worsening. The drug, compared to placebo, gave a 10% reduction in the composite endpoint of cardiovascular deaths or hospitalizations for heart failure. It did not reduce cardiovascular deaths, so we gave that a class 2B indication, something you may consider if the patient's getting worse. We considered a similar recommendation for the cardiac myosin activator omecamtiv mecarbil from the GALACTIC-HF trial. And we voted for the same indication and gave it a class 2B. However, the drug is not yet licensed for use for heart failure in any jurisdiction in the world that I'm aware of. So that's why it's not in a table of recommendations. Regarding using sacubitril/valsartan de novo, that is using it in patients who are naive to use of ACE inhibitors or ARBs, We've given this a class 2B indication, something you may consider, based on two smaller trials, Transition and Pioneer HF, showing that it's safe to start this drug de novo and gives you similar side effects to ramipril. You get a slightly better reduction in N-terminal proBNP. But we've stuck for class 1A evidence as a switch based on the results of the Paradigm HF trial. Thinking a little bit now about device management for patients with heart failure with reduced ejection fraction heart failure, the main change relates to the use of defibrillators. There is still a class 1A recommendation for the use of ICDs to reduce the risk of sudden death and all-cause mortality in patients with HFrEF with an underlying ischemic etiology to the heart failure. But we have changed the indication for those whose underlying cause of heart failure is non-ischemic to class 2A, something we should consider. Why? Because the Danish trial, which looked at ICD use in these patients, did not show a reduction in all-cause mortality for these patients. Some patients did benefit, especially those under the age of 70, but we're saying it's something you should consider. For CRT, I think we've really highlighted as a class 1 indication CRT for those patients with HFrEF on optimal medical therapy who have a wide left bundle branch block morphology with a QRS duration of greater than 150 milliseconds, or who have a permanent pacing system in with a conventional bradycardia pacing system, who are pacing the right ventricle or who are becoming symptomatic in terms of heart failure with their brady pacing systems. We have downgraded the indication for CRT for those patients who have a QRS duration between 130 and 149 milliseconds and a left bundle branch block morphology from class 1 to class 2A, based really on meta-analysis of the CRT trials, showing that these patients don't benefit as much as those with QRS durations beyond 150 milliseconds. So this is what our therapeutic algorithm for the treatment of heart failure with reduced ejection fraction now looks like. So for all patients with HFrEF, you can see that you should be on a RAS blockade, either with an ACE inhibitor or an ARNI, a beta blocker, an MRA, and dapagliflozin or empagliflozin. 4 pillars of disease-modifying therapy. Patients who have congestion, be that peripheral or pulmonary edema, should also have a loop diuretic added to reduce the risk of hospitalizations. Then think about device therapy based on the patient's ejection fraction, the QRS duration and its morphology, and the underlying etiology of their heart failure, be that ischemic or non-ischemic. Then, if the patient remains symptomatic despite appropriate device therapy, consider drug therapies with class 2 recommendations, such as vericiguat, ivabradine, digoxin, hydralazine and nitrate as appropriate. We have included a new table of recommendations for patients who do have heart failure with mildly reduced left ventricular ejection fraction. Now, there are no large randomized controlled trials to guide us here. We're looking at subgroup analysis and meta-analysis, usually of HFpEF trials to guide us here. But when we look at such meta-analysis, we can really see that with ACE inhibitors, ARBs, beta blockers, MRAs, and sacubitril valsartan, for patients with mildly reduced ejection fraction, you seem to get reductions in cardiovascular death or hospitalizations for heart failure, albeit not to the same extent as those less than 40%. But we've given all these drugs a class 2B indication, things you may consider for patients between 41 and 49% ejection fraction. We had some changes to consider in terms of comorbidities, and I'm going to highlight particularly 2. Patients with type 2 diabetes who have HFrEF, obviously, whether you've got diabetes or not, you should be on dapagliflozin or empagliflozin. But for those with type 2 diabetes, also sotagliflozin in the SOLOIST trial did show a reduction in cardiovascular deaths and hospitalizations for heart failure. So that's an option for patients with class 2 diabetes. And obviously for the prevention of heart failure, for those with type 2 diabetes at high risk of cardiovascular disease, we're recommending a number of SGLT2 inhibitors, dapagliflozin, empagliflozin, sotagliflozin, ertagliflozin and canagliflozin to reduce the development of heart failure. The other main change regarding comorbidities relates to iron deficiency, which we know, of course, is common in about 40% of patients with chronic heart failure. We're recommending that we screen all patients for iron deficiency using serum ferritin and transferrin saturations. And if patients are iron deficient and have chronic heart failure and the ejection fraction is less than 45%, treating those patients with ferric carboxymaltose, a class 2A indication to improve heart failure symptoms, exercise capacity and quality of life. And for those patients who've been recently hospitalized for heart failure, if their ejection fraction is less than 50%, we're saying you should treat these patients with intravenous iron, especially if they are iron deficient as well, based on the results of the HFmrEF trial, which showed there was a reduction in hospitalizations for heart failure, treating the patients in this way. Some changes also for patients with atrial fibrillation, a very common comorbidity or indeed etiology. We're now recommending anticoagulation of these patients with a direct oral anticoagulant rather than warfarin. It's a class 1A indication, unless, of course, they have moderate or severe mitral stenosis or a prosthetic valve in situ. We've also got a recommendation for AV catheter ablation for patients who remain symptomatic despite optimal medical therapy and whose symptoms are related to uncontrolled ventricular rate in patients with atrial fibrillation, based on the results of the Cabana and Castle AF trials. Also, we have new recommendations for valve disease, in particular for those whose heart failure is secondary to severe aortic stenosis, a class 1 recommendation for surgical aortic valve replacement or transcatheter valve replacement, the modality to be decided by the heart team. For patients with secondary mitral regurgitation, so secondary to the left ventricular dysfunction, not primary degenerative disease, we have a new indication for percutaneous edge-to-edge mitral valve repair with MitraClip. We've got two different recommendations. For those who have optimal medical therapy, secondary mitral regurgitation, and who don't need a bypass surgery, if they remain symptomatic and they have ejection fractions above 20%, end systolic dimensions less than 7 centimeters, no significant pulmonary hypertension, and a good right ventricular function, we're suggesting you should be considering MitraClip to reduce hospitalizations for heart failure in such patients based on the result of the COAPT study. If your patient is slightly sicker than this and the ventricle is worse or the pulmonary hypertension, you can still consider MitraClip, something you may be considering, but for more palliative indications. And lastly, we have a new recommendation for a specific type of heart failure due to amyloid, particularly for transthyretin amyloid of either the wild type or hereditary variety, for tafamidis, which was shown to reduce cardiovascular deaths and hospitalizations for heart failure in these patients. So to finish with, I hope that I've shown you, in terms of the chronic heart failure management of this guideline, and particularly looking at patients with reduced ejection fraction heart failure, we have a more simplified approach here, looking at 4 pillars of therapy with ACE inhibitor or ARNI, beta blocker, MRA, SGLT2 inhibitors for all. Go on then to consider diuretic therapy as appropriate if the patient is showing signs of congestion, make a decision about device therapy based on ejection fraction, QRS duration, and etiology, but then very importantly, go on to consider the underlying etiology and the comorbidities and treat those appropriately as well. Remember then for all patients to consider whether they may require advanced therapies with transplantation, mechanical support, and offer all patients the benefit of enrollment in an exercise program to reduce hospitalizations, and all patients in a multi-professional disease management program so that the drug therapies, the device therapies are implemented quickly for all patients. It's a big guideline. Remember, there are other derivative products which are perhaps slightly easier to digest, in particular the pocket guidelines, the app, and the official guideline set if you want just a briefer look at things. So I'm going to stop there, and I'm going to hand over now to my colleague, Dr. Antonio Kanata, who is going to hopefully bring the guideline a bit to life and its treatment, but by doing what we all love to do, actually, of course, see and treat patients. Thank you.
Thank you very much, Professor McDonough, for the very kind introduction. And we're going to now move on to a practical clinical case in which we're going to try to translate into clinical practice what we've just learned from the guidelines. So these are my disclosure. I have nothing to disclose. So we met Mr. John Smith, a 77 years old gentleman with a past medical history of long-standing hypertension. He's been admitted approximately 1 year ago with acute heart failure. As soon as he arrived in the hospital, we performed an ECG which showed sinus rhythm with signs of left ventricular hypertrophy. We did an echocardiogram which showed a dilated left ventricle with a severely reduced left ventricular ejection fraction, signs of moderate mitral regurgitation, mild tricuspid regurgitation, and no signs of significant pulmonary hypertension. As a part of workup, we performed a coronary angiogram which showed unobstructed coronary arteries and only a mild disease in the left anterior descending coronary artery. Before the patient has been treated with IV furosemide and has been discharged on ramipril 5 milligrams twice a day, bisoprolol 10 milligrams once daily, and eplerenone 25 milligrams once daily. We then saw the patient at a routine follow-up appointment, and he was still symptomatic for mild shortness of breath on exertion, but he was euvolemic. The blood pressure was well controlled, 116/79, with an left ventricular ejection fraction calculated at 33%. So now we are seeing this patient in our clinic, and what is the next step that we should consider? We're going to switch to sacubitril valsartan, start vericiguat, start an SGLT2 inhibitor, start digoxin, or refer for device implantation.
So we'll get you to vote. So we've got people, yeah, a lot of people voting now. Yeah, we've got another few seconds still to go here. Five seconds left if you haven't made up your mind. Okay, thank you very much. So nearly 100 people voted there. So, Antonio, we have 35% of the audience want to switch to sacubitril valsartan, and 59% want to start an SGLT2 inhibitor. 1% want to start vericiguat, 2% digoxin, and 3% want a device. So maybe
that's great. So actually, yes, this is a tricky one. The right answer at this stage is start an T2 inhibitor, because we know that we have to start the full 4 pillars as soon as possible. In whom and when in all patients with heart failure and reduced ejection fraction, regardless of the diabetes status. Why? Because we have to improve quality of life, reduce the risk of heart failure hospitalization, and increase the survival. Of course, there are some contraindications that, besides the known allergic reaction or the pregnancy status or breastfeeding status, chronic kidney disease with eGFR less than 20 milliliter per minute, symptomatic hypotension, and of course, a special careful attention in patients with type 2 diabetes on insulin because of the risk of DKA. But again, this was very interesting because approximately 1/3 wanted to switch to sacubitril valsartan, and this is something that can be considered also in this scenario. So now let's move back to the case. So Mr. John Smith is a 77 years old with non-ischemic heart failure and reduced ejection fraction, which comes back to our clinic 6 months after optimization of medical therapy, and has pointed out correctly, now is on sacubitril valsartan top dose, 200 milligrams twice a day, bisoprolol 10 milligrams once daily, eplerenone 25 milligrams once daily, and dapagliflozin 10 milligrams once daily. Is still mildly symptomatic, and his blood pressure is still very well controlled, 110/70 millimeter of mercury. He's again euvolemic, and the echocardiogram showed the signs of reduction in the volumes and the diameters, but still is severely reduced ejection fraction, approximately 34%, with mild mitral regurgitation and trace of tricuspid regurgitation. We perform an ECG, which shows sinus rhythm, an heart rate of approximately 72 beats per minute, and a first-degree AV block with a PR of 216 milliseconds and a left bundle branch block with a QRS duration of 128 milliseconds. So again, we see this patient in clinic, and what we do next. What device is recommended in this patient? A CRT-P, a CRT-D, an ICD, an LVAD, or nothing.
So while you're voting, we're obviously going through the algorithm here. We've treated the patient with drugs. We've switched his drugs to the most modern drugs with an SGLT2 inhibitor and switched to sacubitril valsartan, and he's still symptomatic. So we're now on the second level of the algorithm. Do we need to consider a device? 5 seconds to go. Oh, more people voting here. Okay, so very interesting. So 7% of people want to put in a CRT-P. 46% of people want to put in a CRT-D. A third just want to go with the ICD option. 1% want to go straight for the LVAD. And 13% of people have considered the case very carefully and want to do nothing.
And again, the 13% of people had a very well thought, because here we are in the second part of the algorithm. And on the left side, we say that patients have a left ventricular ejection fraction less than 35% and a QRS less than 130 milliseconds. So after the meta-analysis and the ECHO-CRT trial, we know that there is no benefit in those who have a QRS duration less than 130 milliseconds. But since the aftermath of the Danish trial, here we are on the left part of the ICD. So the device is not recommended, but should be considered. And especially in this case, the patient is above the age of 70 years old. So what we know is that the benefit is much more reduced in older patients with non-ischemic etiology of heart failure. Therefore, the correct answer was no device at this stage. Let's go back to the clinical case. John Smith is 77 years old with non-ischemic HFrEF and no class 1 indication for device therapy. We have a routine appointment. Now is becoming more symptomatic. Now is symptomatic on mild exertion. He's in YHA class 3. He has a mild peripheral edema, and the blood pressure is still very well controlled, 113/69. The ECG is unremarkable. It's like the previous ECG, 68 beats per minute, sinus rhythm, first degree heavy block, left bundle with 126 milliseconds of QRS duration. So we want to investigate why it's becoming more symptomatic. So we perform a set of blood tests. The HB in this case is 13.5. The NT-proBNP is 83 picograms per milliliter. The ferritin turns out to be 134 nanogram milliliter. The saturation of transferrin is 18%. We perform a set of thyroid function, and the TSH is 5.9 with an FT3 of 6.1. The creatinine is mildly raised at 1.3 with a potassium of 4.5 milliequivalent liter. So now, what therapy should be considered in this case? A potassium binding agent, introducing of digoxin, ferrous carboxymaltose, levothyroxine, or erythropoietin.
Okay, thank you. So we're now thinking a little bit about etiology and comorbidity and getting the man sorted out from that point of view. We've had one or two questions just while people are answering here. Why do we use ramipril 5 milligrams BD? Well, because in the AIR trial of post-MI heart failure, it was a BD dosing of ramipril. Ramipril 10 milligrams once a day was used in the HOPE trial for prevention. So we tend to use the recommendation for ramipril for the only heart failure trial that it's been used in. Okay, so in terms of thinking about what to do next here, Antonio, 8% want to use a potassium binder, but he didn't have hyperkalemia, I don't believe, did he?
It was 4.5.
Yeah. 8% want to go on and use digoxin. Yeah, it's an option because he was getting worse. 74% want to give ferric carboxymaltose, 10% thyroxine, and 1% erythropoietin. So what do you think?
So in this case, we wanted to go straight to ferrous carboxymaltose because we know that we have to screen patients for iron deficiency. And in this case, his serum ferritin was between 100 and 299 nanogram per milliliter with a saturation of transferrin less than 20%. So this is important to improve symptoms and reduce hospitalization, as we've learned from the HFmrEF and the HFmrEF trial.
And in terms of digoxin, would that be an option as well?
That could be an option. However, what we know is that digoxin doesn't reduce mortality in patients with heart failure. It only has a slight reduction in rehospitalization. So the first thing that we have to do is consider iron supplementation in this patient. But digoxin might be still another option.
And erythropoietin, what do you think?
Erythropoietin in this case, the patient is not anemic, and there is not recommended in patients with a heart failure, therefore shouldn't be used.
Okay, just before we go on, Antonio, I've actually noticed, I can take the blame for this. One of the questions has come in, somebody said they noticed we hadn't actually increased the dose of the MRA of eplerenone to 50 milligrams. We had them at 25. I can't remember whether there was a reason we didn't go up to 50 or...
Well, the potassium of the patient is on the slightly higher side, and then the other thing is that the average dose of the trials was 24 milligram per day, so it was still on a good dose of eplerenone.
It was still at a good dose. Obviously, had he been able to tolerate 50 milligrams, we would have done that, and that's a good point by the one of the participants. Okay, great.
Now let's go back to the patient. Is coming back for a routine appointment after he received a ferrous carboxymaltose infusion. He had a transient improvement in his symptoms, and it was for a couple of months in NYHA class 2. But now is getting worse. So he's again in NYHA class 3, and he's coming more overloaded with a moderate peripheral edema up to the knees. We done the echocardiogram, which showed a progression of the disease, more dilated left ventricle with a severely reduced left ventricular ejection fraction, calculated approximately in the range of the 30%. And what we found on the right side of the screen is that he had a worsening mitral regurgitation. It was mild to moderate before and now became severe. So at this point, what should we do for this patient? Oops. Offload and refer for an LVAD implantation, offload and refer for heart transplantation, offload and refer to the valve multidisciplinary meeting for consideration of percutaneous edge-to-edge repair, start digoxin, or refer to palliative care.
Yep, so people are voting away here. And a few different options, about 10 seconds left to make your mind up, phone a friend. Okay, a variety of responses again. About 3% of people still want to go with an LVAD. Unfortunately, in the UK, we don't have LVADs as destination therapy, and 77, I think that would be certainly not something that we would be able to do. Offload and refer for heart transplant, 1%. Yeah, so the same problem here with comorbidities and age. A bit of a problem for heart transplant. Okay, 94% want to go to a MitraClip after valve multidisciplinary meeting. 2% want to start digoxin and 1% want to refer to palliative care.
So here the correct answer is to offload first, because we always have to look at the patient, and the patient has a moderate peripheral edema, needs offloading, and then refer to the valve multidisciplinary meeting for consideration of percutaneous edge-to-edge repair. But not all patients are suitable for the MitraClip. As we know from the MitraFR and the COAPT trial, only patients who fulfill the COAPT criteria should be considered for a MitraClip. And in this case, the patient has a left ventricular ejection fraction more than 20%. It has a significant dilation, and the LVASD is less than 70 millimeter of mercury, doesn't have a significant pulmonary hypertension, and doesn't have severe right ventricular failure or severe tricuspid regurgitation, and of course is hemodynamical stable. Therefore, the patient has been referred to the valve MDM and has been considered and received a MitraClip, and now is fully optimized and is asymptomatic. So with this, I wish to thank, and we can open the discussion.
Yeah, so regarding the case, obviously, refer to MitraClip, fine. Other people are suggesting, should we increase the dose of loop diuretic? What do you think?
Well, we already brought the patient in to be offloaded, and then we increased the dose of loop diuretics, but still there was a severe mitral regurgitation, especially because the annulus was dilated, and it was there was a lack of coaptation of the mitral valve. Therefore, even after the decongestion, we still have a severe MR.
Yeah, okay. In terms of some of the things that people are commenting now on the case, somebody's quite rightly said, why no ICD? Because it's a class 2A indication and something we should consider. It's not a class 3. It's not something that isn't recommended. I just think that 77-year-old, the comorbidity was the main issue here in terms of not putting in the ICD. But it's certainly, the patient had been younger, had been more up for an ICD. It's certainly something that you can obviously put in. Right, let's see what else. If the QRS had been greater than 130, would we have considered CRT first or a MitraClip? Interesting. I think in terms of the evidence we've got for CRT, it's greater than the evidence base for MitraClip at the moment. And had he had a wide QRS, especially if it obviously been greater than 150, we would definitely have done it, class 1 indication. I think it is something we would have considered if his QRS was wide, greater than 130 in the left bundle branch spot morphology before MitraClip. Do you agree?
Yeah, I totally agree. And actually, the CRT might actually have had an impact also on the geometry of the ventricle then before reducing the annulus and perhaps reducing the indication for a MitraClip. So yeah, I totally agree.
Yeah. Okay. So somebody's also said that we gave ferritin and we gave intravenous iron, but the hemoglobin was normal. So just to remember that the results of the ferric HF trial and of HFmrEF, you had a benefit from intravenous iron whether or not the patient was anemic. So iron deficiency, even in the presence of a normal hemoglobin, needs to be treated. Somebody else is suggesting, you might want to comment on this, Antonio. Some centres of some of the people who are obviously on the webinar tonight don't have MitraClip. Would we have gone for mitral valve repair for surgical repair?
Well, we always have to balance what is the risk and benefit of an intervention. In this case, offloading is the first thing to do, and then maybe we can reassess. Of course, if there is no indication for the MitraClip, we always have to remember that the prognostic benefit of the MitraClip is reduced. It's more symptomatic benefit. Therefore, I wouldn't have gone for a surgical valve repair.
No. And surgical valve repair, certainly we consider for patients who are going for coronary artery bypass grafting. If they have severe secondary MR, you would deal with a mitral valve repair at the same time. But in the absence of coronary artery bypass surgery, the actual evidence for surgical mitral repair or replacement for functional or secondary MR, there are, in terms of randomized controlled trials, we don't have any showing that that's of benefit. Okay, anything else about the patient at this stage before we go on and consider some of the other questions? Okay, we used eplerenone and not spironolactone. Yep, we tend to use eplerenone in men because spironolactone obviously can cause more in the way of gynecomastia and sexual side effects. So that's why we did that. Somebody's going back to the fact that this man had a non-ischemic cardiomyopathy and the new indication of class 2A in the guideline for ICD. Then they wondered about us giving a class 1 indication for younger patients. I don't think you can really do that because then you're looking at subgroup analysis of trials. You have to look at the trial in its totality and its overall result. But we all know, of course, some patients do benefit from ICD, so therefore you have to consider the patient in front of you. And if they are a younger patient, then the benefit will be greater. And we've said this is something you should consider. So we're not saying don't do it. And we're not saying you really have to look at the patient in front of you. Obviously, if they have a lot of mid-wall fibrosis on their MRI, that might also push you towards the ICD, or indeed if they have something like a laminopathy. But this man was 77. So we're not saying don't do an ICD, but we're saying this is something you should consider in non-ischemic cardiomyopathy. It's not something you must do or must immediately rush out and do. Okay, so I think those are the majority of the questions that relate to the actual case. We have some other interesting things that I might just now pick up on. When's the planned update to the 2021 guideline? Well, ESC has a policy usually of updating guidelines every 4 or 5 years, depending on the on the subject and new evidence. So the actual next official heart failure guideline will probably be in 2025 or 2026. However, we are considering a focused update based on the fact that when we actually, the day we presented our guideline, it was published, the HFmrEF trial reported showing, of course, that empagliflozin improved outcomes for patients with HFpEF, but we didn't include that in our guideline, obviously. So where the ESC Clinical Practice and Guidelines Committee are considering whether we should update this guideline. And I think it depends a little bit on the results of the DELIVER-HF trial, which we'll be presenting at the ESC in August this year. And if that also shows something similar, then we would obviously have an indication to change the guideline. It would be something that would perhaps change clinical practice more quickly. So I think the guideline, the evidence is being monitored in the background, and anything else that I think that might update the guideline or change clinical practice quickly, there will be a decision by the ESC and the Clinical Practice Guidelines Committee as to whether it's time to maybe have a focused update prior to the full guideline being revamped, which will be 2025, I would have thought. Okay, so that's that. Interesting question about is there any place for the treatment of a patient with both an ACE inhibitor and an ARB who don't tolerate an MRA, as in the previous guideline? The answer to that is no, because remember that sacubitril valsartan contains an ARB. So you should not really be on an ARB by itself with HFrEF unless you cannot tolerate an ACE inhibitor or an ARNI. The correct treatment for a patient who would previously have been on an ARB would be switched to sacubitril valsartan, unless, of course, they've had angioedema with a previous ACE inhibitor, in which case, or they had a reaction to sacubitril valsartan. It would be perfectly appropriate to keep that patient on an ARB. And there is still a class 1B indication in the guideline for use of ARBs for patients who cannot either tolerate an ACE inhibitor or an ARNI. So you have to be intolerant to both before you should be on sacubitril valsartan, before you should be on an ARB alone. And we do not recommend ACE inhibitors and ARBs in combination for patients with heart failure. Okay, let me just see if there's anything else coming in here in terms of other therapies. Okay, so a few things coming in about vericiguat. Vericiguat should, according to the Victoria heart failure trial, improve symptoms for patients who are optimally medically treated with ACE inhibitors, beta blockers, MRA, ARNI, and I suppose now also SGLT2 inhibitors. They will reduce hospitalizations for heart failure in those group of patients. How do they work? They stimulate rate was above 70 beats per minute in sinus rhythm, there was a reduction in cardiovascular deaths and hospitalizations for heart failure in that group, in addition to optimal therapy with a beta blocker. But our gentleman didn't need that. And also, of course, remember, if Aberdeen shouldn't be used in patients with atrial fibrillation because there's no evidence of benefit there. Okay, would we recommend the patient for cardiac rehabilitation? Yes, we would. Cardiac rehabilitation improves hospitalizations for all patients with heart failure. Another question coming in, is carvedilol better than bisoprolol? I don't know of a head-to-head trial between carvedilol and bisoprolol, so the question isn't answerable. Both carvedilol and bisoprolol have good evidence from randomized controlled trials that they reduce all-cause mortality, hospitalizations for heart failure in patients with reduced ejection fraction heart failure. Is there a benefit for carvedilol? Are there situations you might consider carvedilol? Well, I suppose if your patient's in NYHA class 4 heart failure in the severer group, then obviously the Copernicus study was done with carvedilol in that group. So you might want, if you were being very, very evidence-based, switch to from bisoprolol to carvedilol for those patients. The problem would be, of course, carvedilol is a non-specific beta blocker. It blocks beta 1, beta 2, and alpha receptors. Therefore, it might lower blood pressure a bit more. So it might be something you could consider, but both beta blockers are pretty well evidence-based for the treatment of heart failure. So I don't think that's a major thing. And obviously bisoprolol. So that's why we stuck with bisoprolol. What's the role of hydralazine and nitrate in this patient? Can you?
Well, this patient was a Caucasic patient. Therefore, we know that hydralazine and nitrate, they work much better in a patient from Afro-Caribbean ethnicity. And in this case, we didn't think about hydralazine and nitrate because the blood pressure was very well controlled. Therefore, we already achieved our target with the therapy that we gave. So it didn't need an additional blood pressure lowering agent.
Yeah. And also, we can obviously sometimes use hydralazine and nitrate with patients with renal impairment who can't tolerate blockade of the renin-angiotensin-aldosterone system, but that didn't apply here. Someone's also said about the guideline, having read the latest AHA-ACC guideline, that they've got in their definition a category heart failure with an improved ejection fraction. Again, we didn't specifically put that in our definition because the universal definition of MI was published just at the end of March 2021, so we didn't really have time to consider that. Our definitions are very, very similar to the ACC AHA one, and we've put in the text that about improved ejection fraction, we've just called it recovered ejection fraction. So they're very, very similar. And the main thing, of course, about improved ejection fraction patients who go from below 40 into the mildly reduced or indeed the HFpEF category, that you don't stop their disease-modifying therapy because the evidence from the TRED-HF trial shows that they may get worse if you stop their therapy. So improved ejection fraction or recovered ejection fraction, keep going with the disease-modifying therapies. Okay, and maybe this is one for you, Antonio. Any role of immune suppression for patients with non-ischemic cardiomyopathy?
Well, the immune suppression is mainly used in patients with myocarditis, and especially in the acute phase of the myocarditis. It has a benefit in terms of mortality only in patients with fulminant and gigantocellular myocarditis. But the evidence behind the role of immunosuppression in the acute phase of the myocarditis is pretty various and is debatable because all the meta-analysis and the Cochrane meta-analysis didn't show a clear benefit for immunosuppression. There is a trial that is ongoing using immunosuppression in acute myocarditis, but the results are yet available, and therefore we should look for it. But in this case, specifically, the patient didn't have a myocarditis, had a long history of hypertension. Therefore, we excluded, in this case, the potential possibility of an inflammatory heart disease.
Yeah. I think it's worth considering then as we get towards the end of this webinar that remember, guidelines are not state-of-the-art, cutting-edge documents about the latest treatments in heart failure. They're treatments really for general cardiologists about what is really known about treatments which work, are effective, are safe, and have been used in large randomized controlled trials that we know the vast majority of our heart failure patients benefit from. We all know there are other patients with rarer forms of disease who benefit from other therapies, which can be used on a compassionate use. The guidelines are just guidelines, they're not commandments, but we only tend to really recommend those therapies which have been used in randomized controlled trials, which have a proven safety record and benefit patients. Other things obviously haven't been used in randomized controlled trials like diuretics, but we've obviously data from large registries showing that they improve patients. So drugs, things like immune suppression, we talk about in the text, but we don't give actual recommendations at this point. Okay, let's just thinking if there's anything else here that's useful. Okay, in the unusual scenario that a patient with reduced ejection fraction heart failure who's on all 4 pillars of therapy remains hypertensive, which other therapy would I use? Yeah, good question. Well, I would tend to use a calcium channel blocker, one of the ones which is safer and not negatively inotropic. So amlodipine or felodipine are thought to be safe. Obviously not diltiazem or verapamil. What would I do? I would probably increase the dose of spironolactone, which is a very good treatment for resistant hypertension that we often use in higher doses in patients with hypertension without LV dysfunction. I wouldn't use doxazosin, an alpha blocker, because it tends to exacerbate heart failure. I would use hydralazine and nitrate. And then after that, you're really onto things with an awful lot less evidence, much older, so things like methyl-dopa is another one you could potentially use. Don't go for moxonidine. The MoxCon trial in heart failure showed worse outcomes for patients. Don't use prazosin. There's another alpha blocker. Again, worsening heart failure in those patients. Okay, so they're now polling to see if it was relevant. So I presume that that's time for me to wrap up the situation here. So most people have found it either very relevant or excellently relevant, if that's the correct use of English. So I think we better probably think about wrapping up now. In terms of thinking about closing, the key messages for your daily practice, I would say, remember to diagnose the heart failure syndrome accurately, classify the patient with chronic heart failure according to ejection fraction, remember to look for the underlying etiology and the comorbidities, treat the heart failure syndrome, and if it's HFrEF, with 4 pillars of therapy, get them on board as quickly as you can for the patient. Remember then to think about the underlying etiology and the comorbidities and to treat them to improve the patient's quality of life, their morbidity and their mortality. So it remains for me just to thank Dr. Kanata, especially for the case and his thoughts about why we did the various things we did. Just to say that if you haven't been able to join tonight, or you've had to go out early, or you want to be able to see it again, you will be able to watch this webinar on demand on ESC 365, as well as other patient webinars of the ESC series. So thank you very much and have a good evening.
Thank you.